dental visits. That was the last understanding we
It does
had.
not include dental visits. So those are the types of individuals that are exempt, and that determination is made through their aid codes. There's a specific aid code for pregnancy, for the population under age 21, for Medi-Cal managed care beneficiaries. So that's how that determination is made. But just so you understand, those are the exempt populations. There are also exceptions to the physician visit limit that include the following types of physician visits. And these exceptions are based upon the medical judgment of the physician. So in the medical judgment of the physician, the following would be exempt. The physician's service for this particular beneficiary may prevent an emergency room visit. The physician service may prevent an inpatient hospital admission. The physician service is required to provide ongoing medically necessary or surgical care and/or surgical therapy or treatment. The physician visit is required for a diagnostic workup. The physician visit is required for an in-home supportive services assessment or form completion. So there are some beneficiaries that are going to meet the exemption criteria. They're going to fall under one of the exempted groups we talked about earlier, and there are some beneficiaries that are going to fall under the exception criteria, or both. And the exception criteria is based upon the clinician's medical judgment. In the event that the physician is going to exempt a particular visit, the physicians must document that the beneficiary meets one or more of the exception criteria, and that written documentation needs to be included in the beneficiary's medical chart. Yes.
Does written in this case include electronic documentation?
Yes.
Okay.
Yes. So the physician would need to provide the medical justification for the exemption to the.
Okay. So my question was, if in the situation where a physician is using electronic medical record, that counts as long as if it's in the digital chart, it doesn't have to be written out by hand.
That's correct. It doesn't have to be written by hand.
Is the department working on provisions for how you comply with the attestation requirement in statute? I mean, is there going to be a form? Is there going to be, it can either be a form, it's what's contained in the medical record already, et cetera, because we're talking about a physician who hasn't seen a patient talking about whether the patient does or doesn't need to be seen. So we're kind of into...
I think the expectation is that the physician's medical judgment is documented in the record, and we don't have it's my understanding, we don't have an attestation form developed because it was an extra piece of paper, and it's my impression that based upon our last communications with the stakeholders that it was felt to be onerous. They had to document in the chart anyway, so felt that this was an easier way to communicate their position or their reasoning for the medical justification.
Okay. I wouldn't disagree that it's easier to use the documentation that they're already doing. It's just that making sure that they're not going to run into a situation where their documentation is said to be by the department insufficient, and then we have a situation with a patient who needs care and we're in a back and forth about, because again, they haven't seen the patient. You're asking a physician to determine medical necessity without seeing a patient. I don't know how they do that in the first place, but given that clearly there's a medical record for an existing patient, what counts, so to speak, clarity on that.
So it may be that the physician, this is a brand new patient to this physician. It's unlikely that that would be the case.
Well,
there is that possibility.
Well, and I was going to ask about that because for not your exempted, classes of patients, but your excluded visit types, I mean, they all kind of speak to an established, if your condition is deteriorating, it assumes the establishment of a condition in the first place. So, I mean, all of these kind of use language like that, diagnostic workup in progress. If it's a new patient, they don't have it to that physician, they may not have that. So again, some clarity as to what counts and what doesn't count, so to speak, and whether this even does apply. So the department is seeing this as applying to a new patient visit, potentially the exempted visits. If it was a new patient,
it could, but if it was a new patient, then it's possible that they have not met they've not already had 7 visits.
Yeah, but they could have too. I mean,
But they could have.
I don't. When we say 7, do we mean 7 visits to any physician within the year, right? So if we're talking about a patient that has multiple conditions, or maybe they've been seen for other things. I mean, does a visit to a physician for purposes of securing IHSS benefits, does that count against their limit? I mean, there could have been. Now I see that there's an exemption here that covers IHSS. I don't know if that's everything, but.
So it's going to depend upon the circumstances, and we're going to talk a little bit about the tracking mechanisms that are going to be available to the physicians. And it's going to be, there will need to be a dialogue within the office of the physician so that those determinations can be made. If this is someone that has been referred to a specialist, say, perhaps, and is at their 7th non-exempt visit, then there is the possibility that whoever has referred this individual to the specialist is going to have to communicate that this is part of ongoing treatment and a diagnostic workup so that that can be written into the specialist chart.
Communication that doesn't involve the patient, right? Because then that would be a billable patient visit.
Correct.
Okay. And how does the physician office know when they've hit their 7? It should still be, I don't think yeah.
So we're going to talk about that a little bit further. Sorry. So I want to talk about, we are working with our fiscal intermediary because this is going to be somewhat complex when we implement this through the payment system. And we have developed a list of codes that we believe are going to be applicable to the monitoring process for the physician visit limit. So the following codes, CPT codes, are going to be applicable to the office visits or clinic visits. They would include 99201 through 99215, 99241 through 99245, 99385 through 99387, and 99395 through 99397. And again, we are going to be publishing these slides and these codes on our website, so you'll have them available to you. And the following codes are applicable for physician and office or clinic visits provided in an FQHC, an RHC, or an IHS. It would be 01, 04, 15, 16, 23, or 24. After CMS provides us with approval of the state plan, the fiscal intermediary will implement a system modification so that the limit on physician and office visits billed with the CPT codes that we've just described and listed above will be tracked. The physician service claims for the following will be excluded from the physician visit limit and will be processed by the fiscal intermediary regardless through the standard claim process. Those would be visits for pregnancy, visits for children aged under 21, long-term care beneficiaries in a SNP or an ICF. Again, the AIDS Healthcare Foundation, the SCAN patients, the PACE patients, and those in the Medi-Cal Managed Care Plan, and the Medicare and Medi-Cal dual eligibles. The system and providers will be educated through the usual bulletin process and other trainings. The electronic and paper claims billed using a CPT code that we've indicated earlier will need to include a modifier. And that modifier will be a KX to denote that the beneficiary met the exception criteria. Claims without the KX modifier will count towards the physician visit limit. So say, for example, a patient comes in, has an ongoing medical condition requiring ongoing treatment. The physician, when they bill for that particular patient, beginning on July 1, if that's an exempt visit, will use that modifier. That visit will not count towards the limit. Without the KX modifier, the visit will apply to the limit and be counted towards the 7. Supporting documentation is not going to be required for the claims process. The only documentation that will be required is in the medical record. Hi.
Okay, so my question is, for instance, then for pregnancy, is every service then going to have the KX? Because I'm trying to think, I guess you could have a service with the same CPT code whether they're pregnant or not, but if it relates to the pregnancy, then you had the modifier?
Under those circumstances, your aid code, you're going to have an exception to through the aid code, and so the visits wouldn't apply. The claims are different, as you know, for the F2HCs, RHCs, and the IHSs. So the electronic and paper claims billed using the 2 digits, the codes that we discussed earlier, per visit code instead of a CPT code must include exception verbiage in the attachment. So there's an attachment that will allow you to say meets exception criteria, no modifier, in the remarks field on the claim to justify the physician service. Only the existence of an attachment or remark statement is required for these types of claims.
How will you know, or what will the state do if they want to do an audit? Will you just would come in and randomly select certain visits, or what is the process going to be for auditing of these electronic records or whatever?
It's the usual and customary process where they will ask to review medical records for a particular selection of patients. We talked a little bit about the tracking mechanism and your specific question about how are we going to track this. It's my understanding in the September meeting of 2011, we discussed a reservation system similar to the laboratory reservation system, and there was a lot of pushback from the provider community. A lot of you stakeholders did not feel that that was working adequately currently and would be prohibitive. So we are looking at a number of alternatives. In our discussions with CMS with respect to implementation of a tracking system, we've talked about the possibility of having a system in place that will allow the providers to determine the number of visits. It's got to be a HIPAA compliant system and a mechanism to determine the number of physician visits a beneficiary has received during the fiscal year, and have talked about perhaps the development of a web-based system that's user-friendly, not the lab reservation system, and is a real-time mechanism to track so that the physician doesn't risk a denied payment if it's gone over the they have gone over the 7-visit limit for a particular patient that does not have exceptions or doesn't meet exemptions or exception criteria.
But there would also be a non-web for those physicians that don't.
Certainly, that don't use, yes.
And then what if, is it going to be real time? Because if a physician sees someone because they think they're under the limit and then it turns out something was in the pipes and got approved and they actually were over the limit,